And people who are immunocompromised are the people who can't make nitric oxide, right? So nitric oxide is part of the innate immune response. That's what we saw during COVID. That's what we've seen for the past 60 years with seasonal influenza. The people that get sick and die from COVID or seasonal flu are the people who can't make nitric oxide, right? So the first sign and symptom of nitric oxide deficiency or endothelial function is erectile dysfunction in both men and women, right? Because the sex organs are highly innervated, not just with non-adrenergic, non-cholinergic nerve endings, but also it's highly vascular. So when we become stimulated, the normal response is that the cells of the corpus cavernosum and the male penis generate nitric oxide. We get dilation, we get engorgement, and then we prevent the outflow, and that's an erection. And there's a misconception by a lot of bright physicians. Viagra and Cialis and these drugs aren't nitric oxide dilating drugs. They potentiate nitric oxide signaling.
Welcome back to another episode of the Smarternotharder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Sherr, and it's a pleasure to be back with all of you. Today, I had the pleasure of interviewing Dr. Nathan Bryan. We had a great conversation about nitric oxide, his specialty. So here's a little bit of a bio on Nathan. So he had a Bachelor of Science degree in biochemistry at the University of Texas, Austin, and his doctoral degree from Louisiana State University, School of Medicine in Shreveport. He pursued his postdoctoral training as a Kirstein Fellow at Boston University School of Medicine in the Whitaker Cardiovascular Institute. Incidentally, this is the last time that Nathan was actually sick, and he talks about that during the podcast. It's a long time ago. After a 2-year postdoctoral fellowship in 2006, he joined the faculty at University of Texas Health Science Center at Houston. And there, during his tenure as faculty and independent investigator, his research focused on drug discovery through screening natural products libraries for active compounds. This led to multiple drug discoveries and resulted in over a dozen issued U.S. and international patents. So specifically, Dr. Bryan was the first to describe nitrite and nitrate as indispensable nutrients required for optimal cardiovascular health. He was the first to demonstrate and discover an endocrine function of nitric oxide via the formation of nitrose glutathione and inorganic nitrate. Through drug discovery and natural product chemistry, he discovered multiple unique compositions of matter that can be used safely and effectively generate and restore nitric oxide in humans. His technology has been validated in multiple clinical trials. He's also a successful entrepreneur who has commercialized his nitric oxide technology through the formation of multiple different companies and his own pharmaceutical development company as well. So we had a great conversation during this podcast. Dr. Bryan is a wealth of information. I really wanted to nail down a lot about nitric oxide physiology and understand not just about endothelial dysfunction and endothelial mechanisms, but how nitric oxide works in the red blood cell, how it works in the mitochondria, how it works with insulin sensitivity and resistance, as an antibacterial, as an antifungal, as an antiviral as well. So we dove into all of that. We did also talk about different types of methylene blue, inducible versus endogenous versus neurologic nitric oxide. And we even spoke a little bit here about methylene blue and how it might interact with the inducible nitric oxide, but may actually keep the endogenous nitric oxide supply the same, or maybe even increase it in some cases. We then discussed over to the understanding of how nitric oxide is produced in the body, sources of nitric oxide, how nitric oxide synthase, the enzyme, deteriorates as we get older and why this may be the case. We discussed also Viagra. We talked about chronic inflammation. We talked about what can happen when you have too much nitric oxide and so much more. This is a really fun podcast to record with Dr. Nathan Bryan. I really hope you enjoy the show. If you do, please don't forget to like and subscribe below so you never miss an episode. Enjoy the show. All right, Dr. Nathan Bryan, how are you today?
Great, Scott. How are you? Good to see you.
Another week on the road, another day in one location.
Yeah, for a while. I'm actually up in Fort Worth. We've got a warehouse facility up here where we've taken on our fulfillment, so our business is fully integrated. So we're having our executive meetings up here this week. Yeah, then back on the road.
Yeah, so you're on the road more than I think most people that I know, but that's what we have to do in this kind of business to show the world and to educate the world on what we're doing. And it's interesting because nitric oxide is something now that we've known about for several decades. And I know you were one of the main researchers or involved in this very early on. But I think what most of us don't realize is that nitric oxide has a lot of different functions in the body, not just as a vasodilator. So where I wanted to start off with was just like there's a lot of clinicians that listen to this. And if they're clinicians like me, even up until a couple of years ago, I didn't know the other roles of nitric oxide in the body. So if we can just do a quick rundown and we can go into and dive into some details as we go here of each of them as we go, but let's go like the top 10 list, because I'm sure that's like almost 10 things, or top 10 list. Let's go Dave Letterman style back in the 90s here, back when you and I used to watch TV probably, maybe some people listening here too. Let's talk about top 10 things that nitric oxide does that maybe not as many people know about. You have the floor. Let's see where we go.
Well, I'll take you back kind of the evolution of the knowledge on nitric oxide. So when it was first discovered, it's a vasodilator, right? So it relaxes the smooth muscle of blood vessels and improves vasodilation. So that's number one. Number two, in 2015, it was discovered to be responsible for tissue oxygenation. So when it's bound to the iron of hemoglobin, it actually allows for the allosteric release of oxygen and the pickup of CO2. So it's not just about vasodilation to improve oxygen delivery, but it's also responsible for tissue oxygenation.
So it lets the oxygen dump off
That's exactly right.
the hemoglobin when it gets to the tissue itself.
So as you know, it's
Go
called the Bohr effect. So when the red blood cells go from the arterial side to the venous side to the capillaries, there's what's called a P50, where 50% oxygen saturation occurs, and then hemoglobin, the molecule, actually senses this P50 and it changes its structure. And that's called an allosteric transition. It goes from R to T, or relax, to tense state. And it's during that transition that oxygen comes off, so it's released in the tissue. And then we pick up carbon dioxide, we take it to the lungs, we excrete it, we pick oxygen up. So this whole cardiopulmonary cycle is dependent upon NO bound to a single cysteine residue on the beta chain of hemoglobin. And without nitric oxide bound to that cysteine residue on hemoglobin, you basically lose tissue oxygenation. And, that was what we saw during COVID, was the hypoxemia that was unresolved with supplemental oxygen or even mechanical ventilation, because you have to restore the functionality and the signaling of NO to allow for oxygen uptake and oxygen delivery. So that was really the missing piece in COVID. And, when it wasn't realized, and we had a drug trial ongoing during COVID, but, we could improve blood oxygen saturation from 76 to 98 in 6 minutes, just breathing room air. So there was no need for supplemental oxygen. There was no need for mechanical vents. And our whole strategy was, if you can keep people out of the hospital, keep them on a bed, you can keep them off a vent, then you can keep them alive.
Yeah. Oxygen was certainly, as you probably know, I've also involved in hyperbaric oxygen therapy. And so it's a very interesting time understanding that. And so this is interesting to me, actually, as a sort of, I'm going to leave this point for later because I have a question about this. Because, one of the things we always talk about in hyperbaric oxygen therapy is that we actually are causing a vasoconstriction. And the mechanism behind this, as I understand it, and maybe you understand it better, is related to nitric oxide depletion that can happen when you're under hyperbaric conditions. Do you know anything about that? Or nope, Nathan, I think I lost you for a second.
You froze up for a moment there, Scott. Sorry.
That's okay. No. So the question was, do you know anything about the nitric oxide depletion that happens during hyperbaric oxygen therapy? Have you heard of that before, or why that might happen?
Well, here's what we know. We know that oxygen is required to make nitric oxide through the nitric oxide synthase enzyme. So if you have patients that have ischemic disease or they're hypoxic for whatever reason, then the enzymatic production of nitric oxide in the lining of the blood vessels is completely shuts down. And so nitric oxide, oxygen is required for nitric oxide production. Nitric oxide is required for oxygen delivery. So you kind of have this feed-forward cycle that allows for that. But from what I understand on the mechanism of hyperbaric chamber is that you fully oxygenate the tissue just through improving the dissolved oxygen content, which improves nitric oxide production. You mobilize stem cells, and that's what's responsible for the advanced healing. I'm sure there's many other pathways in play there, but, we look everything, as you know, in the basic sciences, kind of in siloed. What are we doing? What makes nitric oxide? Where does nitric oxide go? What does it become? And how does it signal? So in terms of stem cell therapy, we feel pretty good about the mechanism of nitric oxide being the signal that tells our own stem cells to mobilize and differentiate. So if we can enhance nitric oxide, we can enhance mobilization of stem cells, improve recovery, improve repair, get rid of senescent cells, and allow the body to regenerate.
Yeah. So perfect. And so Another mechanism that I understand is actually happening inside the mitochondria. What is nitric oxide doing inside the mitochondria typically?
Well, there's still some controversy because there was once thought that there was a mitochondrial nitric oxide synthase enzyme. It was so similar to an eNOS, an nNOS, and an iNOS. It was a mitochondrial NOS. I don't think that ever played out because I don't think it's necessary. Because there's a reduction. So we can take inorganic nitride, for example, which is formed from the oxidation of NO. And through that electron transport chain, it really occurs in complex 1 and complex 4, that nitride is reduced, a 1 electron reduction to nitric oxide. And then what does that nitric oxide do? Well, it binds to cytochrome C oxidase, allows oxygen to diffuse further into tissue, and you can improve mitochondrial function. You prevent electron leakage across the mitochondrial electron transport chain. You induce mitochondrial biogenesis. So there's really no need for an enzymatic NOS enzyme in the mitochondria because it has a kind of ubiquitous signaling mechanisms that produce nitric oxide within the mitochondria themselves.
I got it. So it's not about the actual nitric oxide being produced inside the mitochondria. Exactly. It's about the substrate that can go in and create it depending on needs and increase via cytochrome oxidase specifically.
That's right.
Gotcha. Very cool. And then, so talk to me about some other mechanisms because I was reading about, hormone optimization, brain signaling, antibacterial. So talk about those.
Well, so we talked about vasodilation. We talked about tissue oxygenation, regulation of hemoglobin. It's a neurotransmitter. So in the central nervous system, it's what we call a retrograde messenger. It's produced in the postsynaptic terminal, and then it diffuses back through the presynaptic cleft and regulates glutamate, calcitonin-related peptide, number of signaling in terms of synaptic transmission.
Is it glutamate only?
No,
it
controls glutamate transmission. It controls calcitonin gene-related peptide. It's part of the nociception process. It's the mechanism of action of the analgesic effects of opioids. So there are a number of important kind of central nervous system mediated signaling of NO. And then it's a part of our immune system. Our macrophages and neutrophils produce nitric oxide. This is through the inducible NOS that kills bacteria. It generates a lot of nitric oxide over a short period of time, and it binds to the iron sulfur centers of bacteria, shuts down their respiration. If it's a virus, it basically prevents the virus from replicating. If the virus has already penetrated into the cell, if we can mobilize our immune system, then the iNOS shuts down virus replication and prevents it from propagating throughout the body. So people who are immunocompromised are the people who can't make nitric oxide. Right? So nitric oxide is part of the innate immune response. And that's what we saw during COVID. That's what we've seen for the past 60 years with seasonal influenza. The people that get sick and die from COVID or seasonal flu are the people who can't make nitric oxide.
So they can't make the nitric oxide.
The hypertensive, the African Americans had a prior heart attack.
Got it. So you were mentioning something earlier, and I wanted to get into that, which is there's different types of nitric oxide. And let's talk about that a little bit. You mentioned iNOS and eNOS. Let's talk about the differences, where these are, where they get produced, why they're important.
Well, they're named in the order in which they were first isolated and cloned. So nNOS is what we consider NOS1, NOS2 is inducible, and then NOS3 is our eNOS. But we now know that nNOS is not isolated to neurons, and eNOS is not isolated to endothelial cells. eNOS is found in epithelial cells and the epithelium of the sinuses and the upper airways. But nNOS and eNOS are considered constitutive. So that means they're constitutively expressed. I mean, they're active all the time. The iNOS is what we call inducible because it's induced only upon activation by cytokines. So whether it's induction through a lipopolysaccharide from a bacterial infection,
right?
If it's activated through induction of different cytokines from viral infections or a wound injury or an injury that causes a wound, then that upregulates. So with about 4 hours of some type of inflammatory insult, then you start to get rapid genetic expression of this iNOS enzyme. It generates a lot of nitric oxide in a very isolated period, and then it shuts off, and then it goes away. And so that's the acute inflammatory response. The problem becomes is we have, as you know, as a physician, you've got chronically inflamed patients who have really a chronic upregulation of iNOS. And we published probably back in 2004, 20 years ago, really the first indication that there's a negative feedback inhibition on constitutive isoforms of NOS when you get chronic upregulation of iNOS. And we saw this in ulcerative colitis and inflammatory bowel disease, where there's a local inflammatory response in the colon, in the gut, And that local inflammatory response, the upregulation of nitric oxide, forms all these other nitric oxide metabolites that go back and basically shut down the constitutive isoforms. So these chronically...
So they shut down the normal forms.
Yes, it shuts down the normal forms, and then you lose...
Wow.
These chronically inflamed patients develop endothelial dysfunction. They develop, brain fog, neurocognitive, because you've lost the ability of nitric oxide to signal as its normal constitutive process because of the chronic upregulation of INOS. So now we have to fix that, right? How do we shut down INOS? How do we restore the function and production of the constitutive isoforms? And that's really been the challenge, because you have to remove the inflammatory insult in these inflamed patients. And that's where patient compliance comes in, because nobody wants to stop eating and change their diet and lifestyle or move themselves from the source of exposure of toxins.
Now, this is really interesting to me. So it's this feedback mechanism that creates these sort of bad forms of nitric oxide, or nitric oxide that's not really helpful to the system and somehow more detrimental. So it sort of creates one of these sort of downward spiral kinds of things, where then you can't make your normal amounts or your ideal amounts of nitric oxide. And this creates eNOS dysfunction then as well.
That's exactly right. And we measured vascular function and endothelial function in mice and rats with IBS and ulcerative colitis, and they have severe endothelial dysfunction. So people don't associate ulcerative colitis or inflammatory bowel disease with endothelial dysfunction or vascular dysregulation, but we forget the colon's connected through the blood supply, the circulatory system, and those metabolites that are taken up or produced in that local inflammatory environment are systemic. So we have to account for that and understand the crosstalk, the negative feedback inhibition, and fix the underlying issue.
So interesting. I didn't think about that. That makes a lot of sense. And so, typically I don't do this on podcasts, but because we're talking about INOS and eNOS, and I wanted to mention methylene blue here a little bit, because there's been some controversy in this capacity as to how methylene blue affects the nitric oxide system. And my understanding, and I'd love to talk to you about this, Nathan, of course, as the expert in nitric oxide, is that what methylene blue seems to be able to do is prevent the nitric oxide synthase enzyme from converting arginine to nitric oxide, at least in the inducible side. And I don't know if you have any thoughts about this. I guess I'll start there.
Well, I'll tell you what, for the 30 years in the basic sciences, we've used methylene blue as a pharmacological tool to inhibit and really interrogate nitric oxide signal. And obviously, everything is dose dependent, right? But the mechanism of action that we employed through the use of methylene blue in pharmacology was primarily because it oxidizes the heme of soluble guanylate cyclase, primarily. And so it preferentially oxidizes SGC. So then the primary target of NO is blocked. So now you can start to look at cyclic GMP independent effects of nitric oxide, how it's affecting protein structure and function and post-translationally modifying cysteine residues on proteins. But there's also data coming out that, because NOS is a hemoprotein, guanylate cyclase is a hemoprotein, that you can actually get oxidation of the heme of nitric oxide synthase, and that prevents the conversion of arginine to nitric oxide. But again, I don't think it's been well elucidated. What's the dose that preferentially oxidizes the heme of guanylyl cyclase while preserving the redox of the heme iron of NOS, so when you don't disrupt constitutive NOS production? I think that's the $1 million question, right? Because here's what I do. And this is how basic science should be performed, but unfortunately it's not. You take important clinical observations. So what I never deny is, what are the clinical benefits of methylene blue or any other pharmacological agent?
Sure.
Then once you establish a clinical benefit, then it's our job as basic scientists to figure out, okay, what's the mechanism of action? How is this working? What's the optimal dose? And then you can make everything better. And, that's what led to the discovery of nitric oxide, was Fred Murat figuring out how nitroglycerin worked, a drug that had been used for 100 years prior to the discovery that it was actually producing nitric oxide.Wnce you understand that, then you can make everything better. And now custom tailor rational therapies to mitigate kind of the bad things and optimize the clinical benefits while mitigating kind of the off-target effects. And that's what we have to dial in and figure out, what's the optimal dose of methylene blue that you can get to your clinical target but not have off-target effect of shutting down an.
Yeah, and I think that's a really great point. And I think where I see this going is at the very low doses, where we're talking about 4, 8 milligrams, 16 milligrams on the very low scale, certainly do not have a significant effect on that side, at least clinically, from what I can tell.
Yeah.
Now, the higher doses, I think there definitely may be some crossover there. And I think that's super interesting. Of course, methylene blue is used as, in some countries still, for sepsis for this reason, because it does block the inducible nitric oxide to a significant degree and cause vasoconstriction. But anyway, I appreciate your thoughts on it. I think it's important for people to understand the difference between the inducible type of nitric oxide and the endogenous. Of course, there's the neuronal as well, the NOS as well, which
typically, and that may be a viable target, because when INOS is induced, you have about 1,000 to 10,000 times more of that protein and of that enzyme present in a very local spot. So if you're giving methylene blue there, then you're going to have much more of that INOS target than you are of the constitutive isoforms, which are kind of moderately expressed. But there's always 1,000, 10,000 times more of the INOS protein than there is the constitutive. So if you can select for inhibition of INOS without disrupting the production from the eNOS and the nNOS, then you've got a very valuable therapeutic target there.
Yeah, that's really interesting. Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed pharmaceutical-grade formulas in the form of a buccal troche. Check out Just Blue. This is our 16 milligrams pure pharmaceutical-grade methylene blue troche for inflammation, for energy, for detoxification. It's going to help your mitochondria work better. Take it as a troche or even swallow it. The mitochondrial effects will be the same. Start off at 4 milligrams, go to 8 milligrams, increase it to 16 as you need to. Go to transcriptions.com and use code POD10 to save 10% on your order. Now back to the show. So with that said, nitric oxide is something that we all need, and then it declines with age. And so I want to talk about two different things here. So what declines with age exactly? Is it the enzymes themselves, or is it the sources that are just, we'll talk about sources too, but what in the body changes as we get older that makes it more difficult for us to actually release nitric oxide? I mean, you talked about COVID patients that were older. What changes is it in the system to make it more difficult for us to make nitric oxide?
Well, we look at it from both a genetic expression standpoint and then also from the functional aspect. So you can have normal genetic expression of the protein, but if the protein isn't functional, then it's still not going to produce nitric oxide. So it's really the Western lifestyle. It's the American lifestyle. So we know that hyperinsulinemia, hyperglycemia not only disrupt the function of the enzyme, but it actually shuts down the expression of the enzyme.
This is nitric oxide synthase.
Yeah, so the nitric oxide synthase enzyme is not only transcribed and translated into the protein, but what is present is not functional. And so the rate limiting step in nitric oxide being produced by the NOS enzyme is when we oxidize tetrahydrobiopterin. So the NOS enzyme requires 8 different cofactors and substrates, from tetrahydrobiopterin to glutathione, flavin-dependent cofactors, NADPH, heme iron. There's others. But the rate limiting step in all that is oxidation of BH4. And so there's an electrical potential, as you know, that's required to extract an electron from every biomolecule. And as long as you can maintain that electrical potential, we call that the redox potential, the reduction oxidation potential. So reduction or oxidation is a loss of an electron. Reduction is a gain of an electron. So in biochemistry, we're counting electrons, right? And so we have to figure out what's the electrical potential for that particular biomolecule to preserve that electron and prevent its oxidation. And every molecule is different. So we know what that electrical potential is for BH4, but if you're under oxidative stress, if you're chronically inflamed, then not only do you disrupt the membrane potential of cells, but you lead to oxidative stress, and you oxidize a lot of things. You oxidize metals, hemoproteins, you oxidize things like tetrahydrobiopterin, glutathione. So we have to maintain that normal redox balance. But if we can restore the BH4, BH2 ratios, then the NOS enzyme is a homodimer. I mean, there's 2 twins that come together that allow for this flow of electrons, this 5-electron oxidation of arginine to nitric oxide. So that's what we see. When we talk about the age-related decline in nitric oxide production, what we're measuring is the function of the NOS enzyme over time. So we lose about, on average, 10 to 12% per decade. So by the time you're 40 or 50, you have 50% of the nitric oxide you had when you were younger. And those are data that are probably 20, 25 years old. Today, we know that they're 20, 25-year-old kids who have the endothelial production of a 60-year-old. And then I'm kind of the all-important N=1 experiment when I do anything. But I turned 50 in November, but I've got the endothelial age of a 32-year-old. So we know we can shift this curve to the left or right, and we can prevent this age-related decline in nitric oxide production, or we can accelerate it. But it's all dependent on what you put in your mouth, what toxins you're exposed to, and how you live your life. And it's completely preventable.
Yeah. So on the testing side, how do you test for nitric oxide production? How do you test for nitric oxide synthase activity? What are your go-tos here?
Well, the only way to measure this is through functional devices. There's not a biochemical test because once nitric oxide is produced, it's gone in less than a second. And there are a number of different relevant biomarkers or metabolites that reflect kind of nitric oxide flux or production. So there's these old devices, and it's called venous occlusion plethysmography. So what we do is we basically take a blood pressure cuff on the brachial artery and we pump it up to suprasystolic levels. So we basically restrict blood flow into the forearm for 5 minutes. And then either through a fingertip probe or an ultrasound on the antecubital vein or artery, when you release this blood pressure cuff, if the blood vessels dilate, then that tells me they're making nitric oxide. And I call that hyperemia. But if you release the cuff and through ultrasound, if the arteries don't dilate, then those arteries aren't making nitric oxide. So there are a number of devices out there. There was a device called the EndoPad. I'm not sure if it's still there, but most of these are FDA cleared, clinically validated devices. There's others that use non-ischemic plethysmography that look at the kind of the structure and function of secondary and tertiary arterioles that I think are valuable. But that's really looking at the structure of the blood vessels, not the function of them. But it's really the reactive hyperemia that we're measuring that's reflective of functional nitric oxide production and endothelial function.
Yeah, it's so interesting because I had a friend of mine that sent me a new company that just came out that was testing nitric oxide in muscle tissue. And I wanted to try to figure out how they were doing it exactly. So it was supposed to be giving your NO real-time readings. Have you heard companies doing this? And
I think this is from my good friend and colleague, Jonathan Stamler. I think he developed that technology when he was at Duke or maybe even Case Western. And it's called the Fit Strip, I believe, right? So it's looking
I'm not sure. Yeah.
It's looking at tissue oxygenation. And I believe it's a laser device that looks at the oxyhemoglobin content in the muscle tissue.
Okay. So that's how it's doing it.
That's right.
Yeah, there's another company, I can't remember the name right now, but my friend Brian McKenzie, who's in he's a breath guy of CO2 retention, and very much into performance and hypoxia, and was talking about, NO production. And he's like, yeah, I'm using this device. I just put it on my arm and I go into my hyperbaric chamber and I can check my NO levels. I'm like, you can do that?
People are using it, for hyperbaric. They can basically use it during exercise, like on their thigh, if they're pedaling, and see, how well they go on the oxygen or reach their anaerobic threshold. And then you can improve tissue oxygenation. Obviously, you can improve performance. So it's a very valuable device.
That sounds valuable. And then the sense, of course, is that tissue oxygenation requires nitric oxide. And that's something that many people in the world that I live in don't even think about. And many people outside of your world are starting to learn about only now after you've been pounding the pavement for years talking about this stuff. And so I know how it feels. I'm there with you on the hyperbaric side and certainly on the methylene blue side too. That's for sure. Yeah. But so when it comes to nitric oxide production, that goes down as we get older. Where are the main sources of production in general? So internally, externally, where are we getting nitric oxide precursors, and how is it getting sort of through the system and produced nitric oxide overall?
Yep. Well, we talked about the enzyme that's found in neurons and endothelial cells and epithelial cells through our immune system. But there's also a way that we deliver it from the microbiome, the bacteria that live in and on our body. And so now we understand that we can use diet as a way to intervene in terms of nitric oxide deficiency. And this is, as you know, in biochemistry and physiology, there's enormous redundancy. And the nitric oxide field struggled with this for so long because it was thought, if this is such a critical molecule, why is there only a singular pathway to make it through this very complex, complicated 5-electron oxidation reaction? and that it's very easily and is kinetically and energetically unfavorable, there has to be a compensatory pathway or redundant pathway. And we discovered that it's through the diet. So the inorganic nitrate that's found in beets, for example, or green leafy vegetables, when we consume these foods, the nitrate is absorbed in our gut, proximal gut, the duodenum, and then it's intentionally concentrated in our salivary glands. So from the time we eat, let's say, spinach or kale or arugula, 90 minutes after we consume that meal, now we're secreting nitrate through our salivary glands. And then the bacteria that live on the crypts of the tongue, the dorsal part of the tongue, are performing this 2-electron reduction of nitrate to nitrite. And then when we swallow our own saliva, we get a burst of nitric oxide in the acid environment of the stomach. Because the pKa of nitrite is 3.4. When it hits the lumen of the stomach, it becomes protonated and disproportionates into nitric oxide. So now this nitric oxide becomes systemic. And, there was a very important paper we published in 2007. And we discovered for the first time that nitric oxide is a hormone. And so just like any hormone, whether it's testosterone or estrogen, if you're deficient in this hormone, you have to replace it, right? And if you're taking hormone replacement therapy, they're not giving you, diandrosterone or whatever precursors, right? They give you testosterone. For women, they give you estrogen. They're not giving you precursors. So that was our thought with nitric oxide. If nitric oxide is a hormone, all we have to do is generate nitric oxide in a single biological compartment. We don't give testosterone injections into the testes where it's produced. We can give intramuscular or sublingual troches. We just have to get it inside the body. So when we're releasing nitric oxide from swallowing our own saliva, that's a burst of nitric oxide gas in the lumen of the stomach. That's replacing that hormone. And by the way, it kills H. pylori, it kills E. coli, it kills salmonella, it kills Clostridium. So it's a very important part of our immune system. And it allows for gastric mucosal blood flow so you can take up nutrients. Things like selenium, chromium, B vitamins.
So it's actually hypereming, like the actual gastrointestinal,
that's right. So
the stomach itself.
It improves the gastric mucosal lining. It improves gastric mucosal blood flow, so it protects the gastric mucosal from the high acid environment from the pyloric cells. And then and only then can you absorb nutrients. So that's kind of our endocrine or hormone effects of nitric oxide. And then, I developed a lozenge that we bypass the acid environment and we bypass the bacteria because we can create technology that actually repletes and produces nitric oxide in the oral cavity. But the problem comes in when people, number one, they don't get enough green leafy vegetables or nitrate from the diet, or more problematic is people that use mouthwash. There's 2 out of 3 Americans every morning, they wake up and use mouthwash, and there's 2 out of 3 Americans have unsafe elevation in blood pressure. And we published years ago that this isn't coincidental. This is causal.
Is any type of mouthwash?
Any type of antiseptic mouthwash, anything that non-selectively kills. So, when you see the commercials that Listerine kills 99.99% of the bacteria in your mouth, that's a true statement. But I wouldn't be advertising that, knowing what we do today, because it causes an increase in blood pressure. You lose the protective benefits of exercises, and it causes erectile dysfunction. So you may be getting fresh mint for your girlfriend or wife, but you're not going to be able to use that and perform by using the mouthwash and killing the oral microbiome.
Yeah, my goodness. And so what about brushing your teeth? I mean, there are probably safe and non-safe ways to do this then too, right?
Fluoride's an antiseptic. So any toothpaste that contains fluoride is bad news. Fluoride's a neurotoxin. It shuts down your thyroid function and it kills your oral microbiome. So you have to get away from fluoride.
Is there anything else that people typically will use in their toothpaste that they should watch out for? Or is it just the fluoride in the mouthwash mostly?
Well, anything that's antiseptic. So chlorhexidine, for example, these chemical antiseptics, alcohol itself is antiseptic, and then fluoride. So those are kind of the things we worry about. And then the other step in that whole process is the use of antacids. If you shut down stomach acid production, not only have you lost the ability to break down proteins into amino acids and absorb nutrients, but you completely shut down nitric oxide production. And you may have seen the data, I think from 2015, there was reports come out that people who have been on PPIs, these are proton pump inhibitors, Prilosec, Prevacid, Nexium, omeprazole, pantoprazole, people who had been taking those drugs for 3 to 5 years had a 40% higher incidence of heart attack and stroke. And mechanistically, we know exactly why. It's leading to ADMA elevation, which inhibits NOS production of NO. It shuts down nitric oxide production in the lumen of the stomach. And these patients become global deficient in nitric oxide. And then in November, a similar study showed that people who had been on these PPIs for 3 to 5 years had 40% higher incidence of Alzheimer's. If you
Right.
on nitric oxide production, you eliminate blood flow and perfusion, you increase inflammation, oxidative stress, and immune dysfunction, and you develop chronic disease. And you're developing heart attack and stroke. So you have to get your patients off antacids.
Yeah. So what about the H2 blockers of the world? Is it the same thing as the PPIs?
Well, they're not as dangerous as PPIs because it's PPIs specifically that inhibit the DDH enzyme that lead to an increase in ADMA or asymmetric dimethylarginine. But anything that inhibits acid secretion or production from the pyloric cells is going to disrupt nitric oxide production by swallowing your own saliva. You're prone to H. pylori overgrowth. You become nutrient deficient. You can't absorb magnesium. You can't absorb iodine. You can't absorb B vitamins, selenium, chromium. And those are the nutrient deficiencies that most Americans are suffering. It's because they're not making stomach acid.
Gotcha. Yeah. Well, that's a beautiful picture. I just had this like this vision as you were describing it of like this burst of NO every time like it gets down into the stomach, like burst. And
our mothers and grandmothers were pretty wise way back then because I was always told, eat your vegetables and don't spit. That's an inherent way of feeding our nitric oxide production because we're getting the nitrogen from the vegetables. We're getting NO when we swallow our own saliva. So eat your vegetables
and make sure and make sure you take shots instead of, I guess, swishing alcohol in your mouth, right?
That's right.
Although I guess not many people do that, but it's so interesting. Yeah, because I didn't really understand the whole process there and all the mechanisms and the feedback loops, but it's such a beautifully described process, it sounds like. And you mentioned dementia, you mentioned heart issues related to nitric oxide deficiency. What are the first things that people will often notice? Because you're saying that people that are 25 years old now are having nitric oxide levels of 60-year-olds. So what are the things that people are going to start noticing clinically first in their patients when they're becoming nitric oxide deficient?
Well, now we're recognizing there's a hierarchy of symptoms, right? So the first sign and symptom of nitric oxide deficiency or endothelial function is erectile dysfunction in both men and women, right? Because the sex organs are highly innervated, not just with non-adrenergic, non-cholinergic nerve endings, but also it's highly vascular organ. So when we become stimulated, the normal response is that the cells of the corpus cavernosum and the male penis generate nitric oxide. We get dilation, we get engorgement, and then we prevent the outflow, and that's an erection. Similar thing in women. The anatomy is a little bit different, but the clitoris has to become engorged, and that engorgement is due to the blood vessel's ability to make nitric oxide. So if that vascular bed can't make nitric oxide because of endothelial dysfunction, then you don't get dilation, you don't get engorgement. Women become anorgasmic, and men develop ED. So we call it the canary in the coal mine. And so that's the first sign and symptom. And then if not corrected, then you start to see an elevation in blood pressure. Anything over 120 or 80 is typically you're starting to lose the ability to produce nitric oxide. And then full-blown hypertension. And then, we published a paper in 2009 showing that nitric oxide is part of the insulin signaling pathway. So if the cell can make nitric oxide, even though insulin binds and activates intracellular signaling, you don't get GLUT4 translocation and glucose uptake. So you start to develop insulin resistance, diabetes. And then if not corrected, you start to develop mild cognitive disorders. Alzheimer's is considered diabetes type 3, decreased focal ischemia, decreased blood flow, insulin resistance. And then worst case, people who have ovoked cardiovascular disease, nitric oxide stabilizes plaque. So you may have 10, 15% stenosis, but if that plaque becomes vulnerable and unstable and it ruptures, then that's a heart attack or a stroke or ischemic stroke that happens in the cerebral vessels. So nitric oxide, everything we know about vascular biology in inhibiting the onset and progression of cardiovascular disease and preventing plaque rupture is all dependent upon nitric oxide. So we have to be able to understand and recognize symptoms that tell us that our body's not making enough nitric oxide. And then I tell people, just do two things. Stop doing the things that are disrupting it and start doing the things that are promoting it. And then your body heals itself. But the science is complex. The solution is simple, but it takes discipline.
Yeah, to back on the science being complex. So run me through that study that you were just mentioning how methylene blue, that's not that, nitric oxide, excuse me, how nitric oxide can induce insulin resistance. And this is because it prevents the GLUT4 transporter. Can you just go over that one more time?
That's right.
Because I just want to understand if that's related to mitochondrial dysfunction causing NO dysfunction, or is it how's that working exactly? If we know?
Yeah. So there's a transporter called GLUT4, and it's found primarily in muscle cells and liver cells and fat cells. It's normal glucose metabolism. So when insulin is secreted from the pancreas, it binds to insulin receptors. When it binds to the insulin receptor, there's a 7-membrane transmembrane receptor that activates intracellular phosphatase or kinases, PI3 kinase, which then phosphorylates the eNOS enzyme and turns the enzyme on. NO binds to a cysteine residue on GLUT4. Then that tells GLUT4 to go to the membrane and bind glucose cleared from the circulation.
Okay.
And then if you look at AMP kinase, which is the target of metformin, also converges on eNOS. So in patients patients have endothelial dysfunction or their cells can't make nitric oxide, then you can phosphorylate the enzyme either through an AMP kinase by activation of metformin or by insulin. But if the enzyme isn't functional, you don't get nitric oxide produced. And if you don't get nitric oxide produced, GLUT4 never gets the signal to go to the membrane. So you don't clear glucose, get hyperglycemia, tells your pancreas, hey, I need some more insulin. And you get hyperinsulinemia, hyperglycemia, and that's the inflammatory cascade that we know.
Got it.
Diabetes.
Yeah. Thank you for clarifying there. Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice, a nonprofit organization training doctors and practitioners on how to optimize health rather than treat disease. For this episode with Dr. Nathan Bryan, check out the bioenergetics module. This module is for practitioners that want to learn and get a deep dive into mitochondrial function. Vitamins, minerals, nutrients, cofactors, sunlight, water, magnetism, it's all there. And as a clinician, we can understand how we can optimize mitochondrial function using this particular module, using bioenergetics. Go to homehope.org and use code podcast10 to save 10% on this module or any module of the certification course. Now back to the show. And to that end, let's talk about Viagra.
Yep.
Tell me a little bit what you think about Viagra and why does it work, why does it doesn't work? And
well, these drugs were approved and on the market in 1998, and they're called phosphodiesterase inhibitors, right? So these drugs prevent the breakdown of cyclic GMP. And nitric oxide plays a role in this because when nitric oxide is produced, it binds to an enzyme called soluble guanylate cyclase. And this is the enzyme that converts GTP, or guanosine triphosphate, into cyclic GMP. And cyclic GMP is the second messenger that leads to activation of protein kinase G, mobilizes intracellular calcium, and it's that mobilization of calcium that leads to smooth muscle relaxation and dilation. So it's a very complex biochemistry, but the whole point is that PD5 inhibitors prevent the breakdown of cyclic GMP. And so it leads to chronic vasodilation, and that's the reason you're warned against 4-hour erections, an unsafe drop in blood pressure, loss of vision, because nitric oxide turns the switch on, these PD5 inhibitors keep it on, right? But we also know clinically that 50% of the men that have been prescribed these drugs over the past 26 years don't respond. And there's
50%, 50, yes.
And there's a misconception by a lot of bright physicians. Viagra and Cialis and these drugs aren't nitric oxide donating drugs. They potentiate nitric oxide signaling. So in patients who don't respond to PD5 inhibition therapy, they're not making any nitric oxide in the vascular bed of the sex organs to activate guanylate cyclase. So there's no cyclic GMP to prevent the breakdown. So non-responders to Viagra are globally nitric oxide deficient. So now you can give them nitric oxide and improve their nitric oxide production. You can activate guanylate cyclase. You can increase cyclic GMP. Now these drugs will actually work to improve erections or to improve urinary symptoms of BPH.
Has this been shown in studies? Have you guys looked at this specifically, or is this more clinical?
No, we look, again, we take important clinical observations and then try to work backwards and figure out how to make it.
Sure.
But yeah, we've done studies on this where we can take non-responders, and these are patients who have been on 5 milligram daily Cialis for at least 90 days, so they kind of know what their response is.
Sure.
Give them our nitric oxide lozenge, allow a 2-week washout, cross them over, give them a placebo. And while they're on the lozenge, their erectile function, hardness scores improve, their erectile function improves, their urinary symptoms of BPH improve. So it's not just theoretical, it's practical that we see this.
It makes sense. Yes,
potentiate that entire pathway.
Yeah. Are there ways to replete the bacteria in our mouth that increase nitric oxide? Are there companies, are there places, or how would you think about that and look at that?
Yeah, we published a paper, I think in 2019, and we identified really the critical bacteria that are responsible for regulating systemic blood pressure. I filed a number of patents on these, and we were going to bring them to market as a prebiotic or a probiotic.
Sure. Yeah.
But in the FDA's infinite wisdom, they wanted long-term safety studies on non-pathogenic commensal bacteria.
Oh, goodness.
But here's
That
what I
sounds
think.
familiar. Okay.
I think
Yeah.
we can actually, so these are facultative anaerobic bacteria
Okay.
that use nitrate as an energy source. So if oxygen's around, they'll respire on oxygen. When oxygen's not around, then they'll use nitrogen as a source and reduce nitrate to nitric oxide. There's a couple of ways to do this. You can change your diet, get more green leafy vegetables in. And what we're finding now with our lozenge, because it's an oral disintegrating tablet, we're providing a source of nitrogen in the oral cavity that's waking up these nitrate producers. Most pathogens are sensitive to nitric oxide. Non-pathogenic commensals produce nitric oxide. So I think what we're finding, and we're doing a lot of studies with the dental community, is we're selectively killing the pathogens while waking up the good bacteria. What we're finding through our metagenomic studies is that if we can improve the diversity of the oral microbiome, then the good guys take care of the bad guys, and you eliminate kind of the pathogenic guys. And so if that's the case, and we can prove that out, then this transformed the dental community. We figured out the oral systemic link and the mechanism of that. And if we can selectively kill the bad pathogenic bacteria in the mouth while maintaining the integrity of the good, then that's a huge leap forward, because the dental community now,
Totally.
if you've got periodontal disease or gingivitis, they throw an atomic bomb in your mouth called chlorhexidine, and it kills everything. It kills the bad guys, it kills the good guys, and they just wipe everything out.
That's exactly what I was thinking about when you were talking, is that what typically dentists will do for gingivitis is just annihilate everything, just like we use antibiotics to annihilate everything in the GI system.
And there are consequences
small
to that,
intestine.
right?
Yeah, huge amounts of consequences. So the idea here would be, if you can repopulate the oral flora with nitric oxide producers, that you can actually work on gingivitis and periodontal disease at the same time.
For sure. Yeah, in fact, I'm meeting with the American Dental Association in June of this year in Chicago, because they become aware of our science and kind of the issues with dental medicine. Because they're only, medicine today, whether it's dental medicine or specialty, right? Cardiologists are only concerned with the heart. Right? Dentists are only concerned, but we forget the knee bone's connected to the thigh bone, and
Yeah, some people get really, really funny about this, because especially dentists and optometrists, because they like to say that the window into the rest of the body is the mouth or the eyes, or even the dermatologist will say the skin, of course, as well, as being the largest organ, et cetera.
That's right.
Although I guess that's not exactly true. I think the muscles are larger in general, but that's from my friends in the muscle community.
No, I would argue that the endothelium is the largest organ.
So there you go. Yeah. So, and as far as hormone producing, or how would you give it that category or that moniker?
Well, we published this paper in 2007 showing that if we overexpress the nitric oxide synthase in the heart, only in the heart, in cardiac myocytes, it led to ischemia reperfusion protection in the liver. So the nitric oxide produced in the heart led to hepatoprotection from ischemia reperfusion injury. So that told us that all we had to do was produce nitric oxide in a single biological compartment. So if we produce NO gas in the oral cavity, it's absorbed usually, it binds to glutathione, it's transported as S-nitrosyl glutathione, it's oxidized to nitrite. That's transported throughout the entire circulatory system. It modifies proteins, it activates mitochondrial biogenesis, it recouples the electron transport chain. So if you have a heart attack or a stroke, as you know, as a physician, it's not the lack of oxygen, the deprivation of oxygen that causes the damage, it's the reperfusion. We call that reperfusion injury. So when you've got a tissue that's been deprived of oxygen, for instance, the heart, for 1 hour, and you go to the cath lab and they put a stent in and then reperfuse it, it's that oxidative burst that causes the reperfusion. It's because of uncoupled electron transport, you get superoxide, hydroxyl radical, and tissue damage. And nitric oxide completely protects from that reperfusion injury.
Yeah, so look, I love that. I think it's a really good perspective, and it's amazing that people don't realize this is actually a gas, right? This is actually a gas that's being released, and it's diffusing as quickly as it is. And I think, what's the half-life of nitric oxide in general? It's extremely small, right?
Well, if it's produced in the lining of the blood vessel, it has a half-life of about 2 milliseconds, which means that half of it is gone in 2 milliseconds. If it's produced in other cells, it'll stick around for about 2 seconds. And that's really been the challenge of how do we develop safe and effective nitric oxide drugs or product technology, for that matter. And, that's kind of what my 20 years of research and science and innovation has led, is we're the We made the first and only solid dose form of nitric oxide gas. That's not only shelf stable, but it only becomes activated when you put it in or on your body.
Yeah. Yeah. I want to talk about that to finish up in a minute. But my last question would be related to nitric oxide overload, in the sense that we definitely know that like inducible nitric oxide can cause vasodilation and death. Like that's obvious because of sepsis and overwhelming infection. Do we have to worry about this in sort of general clinical practice of people having taking too many of your lozenges, for example, or something else that would potentially be detrimental in having too much NO for a long period of time?
For sure. People die from drinking too much water, right? They get hypotonic lysis and they'll die.
Indeed.
So those dictates poison. What we look for in nitric oxide, there's only two signs of toxicity. One is methemoglobinemia. So if you make too much nitric oxide, it'll oxidize the heme of iron and people become cyanotic and are unable to deliver oxygen.
Right.
The other one, and probably more clinically relevant, is loss of blood pressure, an unsafe drop in blood pressure. And you'll get a drop in blood pressure long before you get any accumulation of methemoglobin. So I tell people, if you take, when taken as instructed, we sold over 100 million of these over the past decade or so, and we've not had a single adverse event reported. But if you take this as instructed, it's kind of like Tylenol. Tylenol is not a good example because it kills a lot of people. But I wouldn't give that one. If you take this as instructed, we don't see any issues. We don't see an unsafe drop in blood pressure. We don't see any med formation. And we published a paper in pediatric patients back in 2012, and we were dosing a rare genetic disorder in a 15-year-old patient, one lozenge every 5 hours to manage his resistant hypertension. But we monitored for med formation, and even taking one lozenge every 5 hours, there was no methemoglobin formation.
Gotcha.
So again, the dose and the amount and the duration of which we deliver nitric oxide, when taken as instructed, there's no issues whatsoever. But yeah, you can't overdo it. If you put 10 of my lozenges in your mouth, then you're probably going to get lightheaded and pass out and become syncope and lose perfusion pressure, and bad things happen when that happens.
Gotcha. Yeah, I would imagine you're doing some research on nitric oxide and blood pressure. This has already been done, but I don't know why we don't think about it more clinically as physicians in general. We'll just leave that. I'll leave that be for now, because I know that's another can of worms. But I'm obviously very interested, and I've been using your nitric oxide tablets with some of my patients with significant benefits in their blood pressure, especially people that have already been doing everything else, like doing exercise, getting their green leafy vegetables. And I think a lot of this has to do with that nitric oxide synthase enzyme just not working as well when you're 80 years old versus when you're 25. And so, Nathan, I do ask a question to all of our guests at the end. This is a little bit off the nitric oxide topic, although you can keep it there if you like. And the question is this: the podcast name is the Smarter Not Harder podcast, and so we ask our guests, what are 3 ways that you can live smarter, not harder? Giving just either general advice or more advice on the nitric oxide too, whatever you decide.
Can you repeat?
The 3 ways you can live.
Can you repeat the question?
Yeah, I can. No, I thought I might have. Yeah. So, what are the 3 ways that you would recommend that we can live smarter, not harder?
Well, I live in this microcosm of nitric oxide, so everything I do is related to that. So I think everything we know about longevity, really, there's 3 main objective measures, right? There's telomere length, there's mitochondrial function, and there's stem cell function. And nitric oxide activates telomerase, prevents telomere shortening. It induces mitochondrial biogenesis, improves mitochondrial efficiency of ATP production, and it mobilizes our own stem cells to differentiate, repair, and replace senescent cells and make cells that work properly. So we have to focus on that. So I tell people the 3 things you got to do is stop using mouthwash and fluoride, get off antacids, and just start exercising and eat a balanced diet in moderation. And it's that simple.
I love that. Okay. And I heard somewhere you haven't been sick in like 20 plus years at this point. Is that right?
No, that's right. I haven't lost a day of work due to illness since 2002. The last time I took a flu shot, I was a fellow at Boston Medical Center, and I swore I'd never take another flu shot again. And even through COVID, I've never had COVID. I was in a clinical COVID site, every week for 2.5 years, and I've certainly been exposed to pathogens. But but look, it's hard work, Scott. You and I we pay attention to our body. We do the things that other people are probably unwilling to do. But if your body's healthy and you got a robust immune system, then we deal with all the pathogens and toxins that we're exposed to.
And fantastic endothelial function.
That's right.
Yeah, perfect. and the burst of INOS when you need it.
Sure.
Nathan, thanks so much for coming on the podcast. Tell us more about your company, your products, and where we can find more about you as well. Yep. Did you hear me?
Yeah, you cut out again. Say again.
That's okay. Well, Nathan, thanks so much for being on the podcast. I really appreciate you taking some time today. I just wanted to follow up, just where could people find out more about you, about your products, et cetera?
Yeah. Well, I'm not here to sell products. I'm here to provide education and update science information. So I send people to my YouTube channel. We'll play this podcast, but I do interviews and lectures on there. I've got an educational website, drnathansbryan.com. There's some videos on there that'll inform and educate. I do a monthly blog. And then for those interested in our product technology, it's www.n101.com. That's nitrogen, the number one, the letter O for oxide, the number one.com, n101.com. I've got a drug company. We're taking drugs through the FDA. That's BryanTherapeutics.com.
Oh, nice. I didn't know that. Okay.
Yes, we've got drug programs in heart disease, Alzheimer's, and topical drugs for diabetic ulcers.
Oh, wow. That's quite the process you have going on. Yeah. The Bryan Pharma. I like it. Okay. Well, thanks so much, Bryan. Nathan, excuse me. Bryan, I was thinking about your last name. Thanks so much, Nathan, for being here. Right. I really appreciate your time.
Thank you, Scott. We'll see you around. Thank you.
Okay. Take care. Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. This podcast was an amazing one to record. I learned so much about nitric oxide and all of the major mechanisms that are happening and how we need to get more nitric oxide in the body, make our enzymes work better, and we can optimize our cardiovascular, our brain, our genital organs, and everything else in between. So I hope you enjoyed it. If you did, please don't forget to like and subscribe below so you don't miss another episode of the Smarter Not Harder podcast. We'll see you next time.